So hey guys, I'm coming to you with a new video. I know I said I was gonna post it yesterday, but I'm actually working on my BSN, so I got a little bit busy with doing my assignments because I'm actually working Saturday and Sunday and I needed to submit my assignment by Saturday. So I just wanted to make sure I did all of that, and today was my day to just kind of relax, chill, wash my uniform, and get prepared to work for this weekend. So I am on orientation, working at the hospital, and I just want to give you just some tips based on my experience thus far. I've been working as a nurse for 45 days, and I've had my license for 47 days, literally 2 days more. Yeah, so let's start. Most hospitals, when you do your orientation, they're going to have you do in classroom orientation. So, just to kind of cover the hospital's policies, how to use the hospital software, how to assess wounds, how to do venipunctures, things like that. Um, it's good, it's helpful. Is it 100% like proficient? No. It's you going to the floor and getting that experience is definitely going to make the ultimate difference, because I think at this point, especially as a new nurse, your primary focus is going to be building that muscle memory. So, my first week, of course, you have a preceptor. The preceptor kind of trains you of what to expect, what to do while you're on the floor, how to do telephone orders, how to view the MAR, how to give meds, how to use the Pyxis, everything. So I would say like the first week or so, I felt a little bit overwhelmed. Because like my precept is pretty fast paced. Like, okay, don't forget we gotta do this, and that. And I just kind of felt like what's going on? Like I felt like almost like I was drowning a bit. But I started to like we started with I think we had like four patients. Okay, yeah, we had about four patients. So I'm like, okay, that's not bad. Sorry if the camera's so shaky, guys. So I said, okay, that's not bad. So then she was like, hey, I'm gonna give you a patient, and like you're gonna follow that patient. I would definitely suggest, and I know it's such a scary like prospect, but I would suggest the minute you feel semi comfortable to discuss with your preceptor taking on patients for your own. I think it's important for you to have that one patient and follow them and follow just the entire day's process for them. Doing pain assessments. If they're on opioids, doing the MOS scale. Is it appropriate to give this person? If this person's lethargic, should I still give them 30 more milligrams of oxycodone? Should I still be allowing this PCA to run if they're constantly lethargic and difficult to arouse? And if so, who is the doctor? How do I know about contacting the doctor? Just that entire process. If is that person out of bed? What is the order? Should they be using a sensorsoprometer? Do they have PT? Has PT come around and seen them yet? I think it's important to just kind of go through that whole process. What's their diet? Is it a regular diet? Are you ensuring that dietary is bringing them the appropriate things? Just different things so you can see what possible challenges or things need to be taken care of for that patient throughout the course of their day. And then once you kind of get the idea, which I would say even at my day 45, I'm still not 100%, but I feel like I am like maybe 70 to 80% proficient. 70 to 80. So yeah. And then build up to two. How are you going to manage your med times? If that you have two people at 10 o'clock that have antibiotics due, or say for instance you have three patients, you have two with antibiotics due, one needs allopurinol for a gout. Who are you going to give medication to? Do you think it's more important for the person who has gout to get their medication, or that person who is on vancomycin daily and has Vancotroph taken? Which one is a priority? If you're not quite sure, I'll give you a hint, is the Vanco. The antibiotics have to be given at the time that they are due. I cannot stress that enough. I definitely have learned that because right now I have, with my preceptor, of course, I have 4 or 5 patients at a time, and I cannot tell you how often I look at my patient's meds, and I'm like, okay, you're on oxycodone, you're on Vanco, you're on allopurinol, you have Relistor because you need to poop. Which one is more important? Like the allopurinol, that's going to be, you'll be the last person I see because that's for gout. If you're not having an active flare up, it's not necessary that I give it to you right at the 10 o'clock hour. The person who hasn't pooped, are they symptomatic or are they not symptomatic? They're complaining of mild constipation and cramping. I'm going to get to you. You'll be the second to last. You'll go right before the allopurinol patient. Okay, I got another person who is on Zosyn. Okay, that's an antibiotic. I'm going to make sure that you get it. Say, for instance, the doctor told you, your infectious disease doctor told you that I'm going to order a Vencotrof for this patient tomorrow at 4:30 because they get 6 o'clock. I'm going to make sure I hang that Vanco first, because if you hang that Vanco late and then that Vencotrof is done the next day, guess what? It's going to look like the Vanco should be held when it honestly shouldn't have. So if you have that Vanco due at 10 o'clock, honestly, 9 o'clock, you want to try to hang that bag. It should not be 11 o'clock, 11:30, you're trying to hang that bag. These are the things that I learned. So you want to get stuff like that, because by you doing that medication in particular late, you ultimately mess up the doctor's interventions, which he has the best intentions, but maybe he wasn't aware that Vanco was done late. So now an intervention may be unnecessarily done for a patient because you hung that medication late. So those are things to consider. So I know the biggest question is like, okay, I'm a new nursing student. I'm not a nursing student. I'm a new nurse. How am I going to manage all of these things? How am I going to have 5 and 6 and 7 patients? I haven't gotten to 7 patients. Thank God, the maximum I've had was 6, and I did okay with managing. Primary thing I would tell you: cluster care. Cluster care, cluster care, cluster care, cluster care, cluster care, cluster care. Like, seriously, no, like, I cannot stress it enough. Cluster care. If you have 5 and 6, 7 patients, you do not have the time to go hang a medication and then walk out of the room and then go back in and do a vital sign and then go back in and ask them if they have a bowel movement, and they say, oh shoot, you know what, we're supposed to be doing this, and then go. You don't have time for that. Cluster care. Try to get everything done as soon as possible for that patient while you're in that room. I don't have it on me, particularly because their patients' names are on it, but this is what I do every day. If I have, like, I'll give you an example. I'll do it easy. 4 patients. If I have 4 patients, I take a blank sheet of paper, right? And I take the paper and I put a line down the middle and a line through the cross, so it's 4 equal boxes, right? And I have, say for instance, I'm going to make up fake names. Diane Sawyers, 828. Room 828. Michael Jackson, room 829. Kobe Bryant, 830. I don't know why I'm thinking these random names. And John Smith, room 831. That's what I'll do. So I'll create like a cheat sheet for each individual patient. On each and every one of them, I'll put a line. It says, okay, IV date. So you see, okay, if that IV was put in 2 days ago, you have the date, it doesn't need to be changed. You're good. If you go to check that IV, you see it's 96 hours. What are you doing? You're going to change that line. So you put the date on there. You put IV line date. So say, for instance, person's on piperacillin or Zosyn, I'll say the easier name for it, and that tubing was put up 4 days ago. You got to change it. So you want to make sure you're checking the IV date, the IV line date. You want to make sure you star a box for when that person have bowel movement. Another thing I do is orders. I check the order. So if a consult was put in, say for instance, their primary doctor put in a consult to infectious disease or pulmonology or whomever, looking to see, was those consults called in? If you see they're called in, you check off that box. Bowel movement, you check off the box. IV line, check off the box. PT. If PT is ordered for them, did PT come around and see them? If you see the notes or what have you, that's done, you check off the box. Boom. What are some other orders? If, say, for instance, they have a stat blood culture, did somebody come up? Is there pending, or is there, you have, if you see if it's pending, you check that off. I also created another box for the actual results. Say, for instance, you have somebody whose blood cultures come back and they're growing an organism. You need to call the doctor for that. So you want to make sure that you have one to ensure the blood work's actually done, and a checkoff box to ensure that you have the results and that you've notified the doctor. I'm trying to think of some other things. IV lines. If they have a catheter, is there order to DC a catheter? You want to look at that. If that person's post-op day one, and say, for instance, they are on a full liquid or clear liquid diet, put a checkbox to say, you know what, maybe I should reach out to the doctor, let them know, hey, listen, this person is post-op, they haven't had any complications thus far, they're out of bed, they're ambulating, can we DC this Foley? You put that, and once they say yes, you check it off. You say, Doctor so and so consulted, check it off. Their diet that you spoke to the doctor to say, hey, you know what, let's go ahead and advance their diet from full liquids to soft chopped. Okay, Doctor so and so consulted, you check off the box. You want to just kind of create like a cheat sheet, so it gives you a sense of what you have done throughout your day, which makes it great for you when you go to do a report. You're not fumbling through the Cardex. You can say, okay, especially if, say, for instance, the night nurses already worked with that patient before, they just need the new updates. You don't have to go through the history. You can say, listen, spoke to infectious disease, the Venko trough was done. This is the Venko trough. I still gave it. Boom, they had a bowel movement today. PT saw them. Boom. The Foley was DC. Boom. A diet advance. Boom. You want to be able to kind of give yourself a cheat sheet so you can go down the list and make sure you're not forgetting things. That is a primary thing. Also, I put in there who's the attending doctor. I'm trying to think who's the attending doctor, whether or not there's a discharge plan. Sometimes you're not able to see the doctor to speak to them in regards to a discharge plan. And a lot of times during the day, you have a what's called an interdisciplinary team meeting. So it could be you, your nurse manager, the case manager, the social worker, and maybe somebody from dietary. And we all basically sit down and discuss what's going on with this patient and whether or not there's a plan for discharge. That team is going to look to you as the nurse who is working with that patient directly to say whether or not there's a plan for discharge. And like I said, if you don't have the opportunity to meet with the doctors, you can always look through the notes and see, like, because a lot of doctors may write, outpatient follow-up, discharge pending, blood culture results, which is why I said you need to make sure you're checking up on the blood cultures, toxicology reports, chemistry reports, hematology reports. See what's going on with this patient. Get a full snapshot for yourself, because the last thing you want is to have a doctor come and ask you, like, okay, I saw, how was the CT results? And you're like, I don't know. Okay, did the blood cultures come back? Oh, I didn't even know they were ordered. What was their Venko trough level? Oh, I don't know. That's the last thing you want. You want to actually, when you see the doctor, hey, just want to let you know the Venko trough is 31.5. Do you want me to hold it? Obviously, you will hold it because it ranges 18 to 26. But you want the confirmation for them. Hey, are you going to put that order in, or do you want me to put it in as a telephone order? Just different things that you can do to kind of move things along. Not to say the things like that are done intentionally, like where a patient is, a doctor's not, right on top of their discharge. Doctors are busy. Sometimes you have to be, not even sometimes, you are that patient's advocate. You have to advocate for that patient and say, hey, listen, this is the results I got. What would you like for me to do? This person's reporting pain. I see you have a PRN order for Tylenol. That's not really improving it. Can I give them Tramadol? Can I give them oxycodone? What is it that you prefer I would give them? Because the 650 of the Tylenol is not providing them with relief. You are there to advocate for that patient. I'm trying to think of what else. Like I said, cluster care. If you're giving a patient a medication, say, for instance, you're giving them metropolol, right? You got to do vital signs anyway. Get everything done. While you're putting that blood pressure cuff on and you're doing the O2 sat and you're doing the temp, ask that patient, hey, by the way, did you have a bowel movement? Okay, you did? When's the last time? What did it look like? Get all the information while you're in that patient's room. So you're not constantly running in and out because you don't have the time for it, honestly. Especially if you have somebody else who has a equally as important medication due for Vinco. Like I'll give you an example. I have a patient that, and you're gonna have patients like this too, that really enjoy your company and don't necessarily want you to leave. You have to know and kind of give yourself a sense of, well, whose room can I get out of a little bit more quickly? And it's not to say like you don't want to be there, but you have to be, mindful that you're working on time constraints when you're giving medications. If you have that patient who talks about everything under the sun, and even with you, you're at the doorway and you're kind of giving that body language sign of, hey, I gotta go, and they're still talking, maybe that's not the first person you should go see, because guess what, they're gonna throw you off for the rest of your medications. Maybe you should go see the other patient who's a little bit more passive and just may talk to you a few minutes, just check in, and they're good. You can be done with that person more quickly. Maybe you want to, devote that person who's a little bit more talkative or needs a little bit more of your time and attention. Maybe you want to devote them towards the end of your medication administration, so that way they're not feeling like they're being rushed, because that's, at the end of the day, we still have to worry about patient safety, patient care, and patient satisfaction. And it's not like these patients are not doing it with ill intentions, like, oh, I want to hold the nurse up because I want to make them late. Just think about it from their standpoint. They may not have family who shows that much interest in them or are concerned in their care. You may be the only person who has lended them your ear and has been able to empathize with them, sympathize with them, and maybe offer some suggestions that can help. And that's why they kind of are clinging to you in that moment. So, don't dismiss that person like, oh my God, he's so needy. You might be all he has in terms of somebody who's shown some consideration and some care. So I think, I'm gonna basically end it here. This is actually my shortest video. Just to summarize, you are the advocate for your patient. It's important for you to cluster care. Always be mindful of patient satisfaction and do your very best to make sure that patient, even if it's the minimalist bit, has some improvement in their quality of care. So this is Chandra RN signing off. I wish you all the best of luck. Good luck on your orientation. Not all nurses eat their young. I would have to say personally, the nursing staff that I'm working with are extremely supportive. I caught so much hell with putting an IV in a patient. His skin was very thick, and despite my best efforts, I wasn't getting any blood return. And I had two nurses step in, because the second nurse who came in, she couldn't get it either. And she's like, oh my God, what's going on? And I had a third nurse come in, she helped, and she said, you know what? Don't give up, Chandra. Never give up. And I'm going to say that all the same to you all. Never give up. Continue to try. Continue to do your best. That's all you can. That's all you can do. Be the best nurse you can be. Again, this is Chandra RN signing off. God bless. Bye.